1, 2,
And review, somebody female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the phone.
It's,
300 please.
I'll keep your card again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Imagine you break your arm, right? You go to the hospital and, well, the x-ray is entirely binary. It's clean. There's this jagged white line. The doctor points to it and says, there it is, broken.
Right. Yeah, it's precise.
Exactly. But the moment you step into the neurointensive care unit, that kind of certainty just completely vanishes. You're staring at a patient's monitor. Their skull is perfectly intact, but inside, I mean, their brain is trapped in a literal pressure cooker.
It is deeply unsettling the first time you experience it. You know, you're operating in this time-critical, zero margin for error environment, and the actual damage, it's entirely hidden from the naked eye.
It's terrifying. So we are taking a massive stack of neurocritical care source material today, and we're going to look at it through a very specific lens. We're aggressively applying the 80-20 rule.
Right, the Pareto principle.
No. Exactly. We want to distill down the exact pathophysiology, the bedside assessment, and the priority actions that will, literally save a brain from irreversible damage.
Yeah.
So if you're listening right now, we know you're ready to level up your clinical reasoning. We're going to walk through this using what we call intensivist thinking.
Yeah, and intensivist thinking it's a highly structured cognitive model. It moves sequentially. So you identify the problem, you trace the failing physiology, which then reveals the immediate threat to life.
And that dictates the intervention.
Right, the specific intervention, and finally, reassessment. We aren't going to get bogged down in low-value textbook trivia today. We're focusing purely on what will kill the patient first, what will immediately change your treatment plan, or what represents a classic cognitive trap at the bedside.
I love that. So to start, before we can treat specific brain injuries, we really have to understand the physical laws governing the brain.
Yeah.
Because every single neuroemergency eventually leads back to one fatal problem.
Too much pressure in a closed box.
Exactly.
Yes, the core syndrome underlying everything we'll discuss today is increased intracranial pressure, or ICP. And, well, to understand the mechanics of increased ICP, you have to understand the Monro-Kellie Doctrine.
Okay, so think of the skull like a strictly regulated VIP club. The club is at absolute maximum fire code capacity. You've got exactly 3 components in there. You have the brain tissue, let's call them the regulars, taking up about 78% of the room.
Right.
Then you have the blood network, the staff, making up 12%. And you have the cerebrospinal fluid, or CSF, let's say they're the bartenders, making up the remaining 10%.
I like that.
The doors are locked. The walls are bone. So if an uninvited guest forces their way in, say a bleeding hematoma, a growing tumor, or just massive cellular swelling, someone else has to be kicked out, or the walls of the club are literally going to explode.
That analogy is perfect because it highlights the mechanism of compensation, right? When that uninvited guest enters, the brain's first move, the bouncers, if you will, is to displace volume.
It kicks people out.
Exactly. It physically shoves CSF down into the spinal subarachnoid space out of the skull. Or it collapses cerebral veins to push venous blood out. But, and this is crucial, that compensation has a very strict physical limit.
Right. Eventually, the bouncers just run out of room.
Exactly. Once that compliance is lost, decompensation occurs. The intracranial pressure, which normally sits calmly between, say, 5 and 15 millimeters of mercury, rises above 20. And this is where the physiology turns lethal.
Because when ICP goes up, cerebral blood flow goes down.
Yes.
Because the physical pressure inside the skull is so high, it's actually acting like a wall, resisting the fresh arterial blood trying to pump in from the neck.
Precisely. That resistance causes decreased blood flow, which leads to tissue ischemia and hypoxia. The brain tissue starts starving for oxygen. And, here's the cruel irony of the brain.
What's that?
When it starves, it gets inflamed and swells.
Oh, wow.
Yeah, that edema drives the ICP even higher. It's a lethal feedback loop. If you don't break that loop, the pressure forces the brain tissue downward toward the only exit the base of the skull.
Which is brainstem compression.
Right. Fatal herniation.
Okay, let's connect this to the numbers we actually see on the monitor, specifically cerebral perfusion pressure, or CPP. The formula we use is CPP equals MAP, your mean arterial pressure, minus your ICP.
And a normal CPP is between 60 and 100.
Right. And as an intensivist, you know that if CPP drops below 50, the brain is ischemic. If it drops below 30, you have irreversible neuronal death. But wait, I have to push back here.
Sure, go ahead.
Because this is where my instinct fights the math. If the pressure inside the head, the ICP, is already dangerously high, why do we want a higher systemic blood pressure, a higher MAP? Doesn't high blood pressure cause more bleeding or swelling? I mean, don't we normally want a lower high blood pressure?
This is exactly the cognitive trap that catches novice nurses at the bedside. Your intuition says, lower the pressure, but you absolutely must maintain a higher systemic blood pressure when ICP is elevated. Let's do the math.
Okay.
If your patient's ICP is 25 and their MAP is 70, their CPP is only 45.
Well, so the brain is actively dying.
Yes. You need that MAP higher, sometimes artificially driven up with vasopressors, just to overcome the immense physical resistance inside the skull and force oxygenated blood into the tissue.
That is fascinating. You're essentially using systemic blood pressure as a battering ram to get oxygen through the intracranial resistance.
Mm.
Okay, so how do we catch this failing physiology at the bedside before the brain starves? Let's walk through how a nurse actually approaches this, from early assessment to late-stage deterioration.
The earliest, most sensitive indicator is always a change in the level of consciousness, or LOC. The cerebral cortex and the reticular activating system are incredibly sensitive to even minor oxygen deprivation.
So we aren't necessarily looking for a coma right away. It might just be like a subtle flattening of their affect, a delay in answering, or suddenly they don't know what month it is.
Exactly.
But what about the late, terrifying findings? Like the patient is getting worse
If you see a fixed unilateral dilated pupil, the patient is in extreme danger. That means the brain is already shifting off the midline, and it is physically crushing cranial nerve 3, the oculomotor nerve.
Oh, wow.
Yeah, that indicates uncal herniation is actively happening.
A blown pupil is an absolute emergency.
Yeah.
And what about the vital signs? Because there is a very specific late-stage vital sign trend that screams brainstem compression.
You're talking about Cushing's triad. This is the physiological alarm bell of impending death, and you have to understand why the body does it. As the ICP skyrockets, the brainstem starts starving for oxygen.
Right.
So in a desperate attempt to force blood up into the brain, the sympathetic nervous system kicks into overdrive, violently clamping down on systemic blood vessels. This causes massive systolic hypertension with a widening pulse pressure.
So the top number on the blood pressure just shoots through the roof.
Exactly. But then, the baroreceptors in your aortic arch sense this dangerously high blood pressure. They panic and trigger the vagus nerve to slam the brakes on the heart rate.
So you get profound bradycardia.
Right. The third piece is irregular respirations, because the physical pressure is directly crushing the respiratory center in the brainstem. Systolic hypertension, bradycardia, irregular breathing. If you see that triad, the brainstem is actively being crushed.
Okay, let's talk diagnostics and how we actually measure that pressure. The gold standard is the ventriculostomy.
Yes, a catheter inserted directly into the lateral ventricle to measure pressure and drain CSF. But the bedside pearl here involves physics. The external transducer must be perfectly leveled with the foramen of Monro inside the brain.
And the anatomical reference point on the patient's face for this is the tragus of the ear, right?
Exactly. If the bed moves, you have to re-level it, or your numbers are garbage.
And when we look at the ICP waveform on the monitor, a normal wave looks like a descending staircase with 3 peaks, P1, P2, and P3. P1 is the arterial pulse, so it should be the highest.
Right, but if you look at the monitor and P2 is higher than P1, intracranial compliance is severely compromised. The brain has lost its ability to compensate. That rising P2 wave tells you the club is full and the walls are about to give way.
That's a huge early warning sign. Now, there is one massive diagnostic trap we have to mention from the sources. If you suspect increased ICP, you never do a lumbar puncture. Can you explain the physics of why that is so dangerous?
Think of the skull and the spinal column like a sealed vacuum tube filled with fluid. The pressure at the top, inside the skull, is incredibly high. If you suddenly poke a hole at the bottom of the tube, which is what a lumbar puncture does in the lower spine, all that high-pressure brain tissue at the top is going to violently rush down toward the exit.
Oh, man.
You will literally vacuum suck the brainstem down through the foramen magnum at the base of the skull. It causes instant irreversible herniation.
The vacuum effect. That makes perfect sense. Okay, let's get into priority nursing interventions. What is the very first action?
First, Elevate the head of bed to 30 degrees and strictly maintain the head and neck in a neutral midline position. You're using gravity to maximize venous drainage out of the head, but if their neck is twisted, you kink the jugular veins, trapping the blood in the skull and spiking the pressure.
Next T, secure the airway. The intensivist rule of thumb is less than 8, intubate. If their Glasgow coma scale drops to 8 or lower, they've lost the reflex to protect their airway. Then we have to manage their metabolic demand. We know fever increases metabolic waste and vasodilation, which drives up ICP, so we cool them. But a common mistake is throwing ice packs on them to freeze them rapidly. Why is that bad?
Because if you cool the human body too fast, it shivers. Shivering involves massive whole-body muscle contractions that dramatically increases the body's metabolic workload, demanding more oxygen, which ironically spikes the ICP you were trying to lower.
Wow.
Yeah, you must cool them slowly and use targeted sedatives if shivering occurs.
Let's look at the heavy hitter medications for ICP, mannitol and hypertonic saline. How do they actually work?
They both work through osmosis. Mannitol is an osmotic diuretic. When you push it into the bloodstream, it creates a massive osmotic gradient. It's essentially a giant sponge in the blood vessels that physically pulls fluid out of the swollen brain cells into the blood, and then it goes to the kidneys to be peed out. You must monitor serum osmolality.
And hypertonic saline.
It does the exact same thing, pulls fluid from the intracellular space into the intravascular space, but you have to closely monitor serum sodium levels and blood pressure because you're dumping salt and volume into the vascular system.
What about corticosteroids like dexamethasone to reduce swelling?
This is a classic cognitive trap. Corticosteroids are only used for localized vasogenic edema around tumors and brain abscesses. They are strictly not recommended for traumatic brain injury. They don't improve outcomes in trauma and actually increase the risk of infection and GI bleeding.
So synthesizing all of this into a clinical picture, if you're at the bedside and you see a patient with a declining GCS, a suddenly blown pupil, and a widening pulse pressure with bradycardia, that patient is actively herniating. And if you're looking at the monitor and see a rising P2 wave, you need to think poor brain compliance, immediately ensure the head of the bed is at 30 degrees with the neck straight, and prepare to administer osmotics like mannitol or hypertonic saline to pull that fluid out of the brain.
Exactly. You are fighting for space inside that box. So remember the 5 things here. 1, Monro-Kellie Doctrine volume increase kills tissue. 2, LOC change is early, Cushing triad is late. 3, brainstem herniation is the ultimate danger. 4, elevate HOB and secure the airway. And 5, treat with osmotic therapy and keep that CPP above 60.
Perfect. So we've talked about what happens when the pressure inside bleeds up, but what happens when blunt force trauma physically breaches that VIP club, tearing the structural blood vessels? Let's apply our ICP rules to trauma and hematomas.
When we talk about the 80-20 of hematomas, there are 2 distinct types you must instantly differentiate based on their mechanism: the epidural hematoma and the subdural hematoma. An epidural hematoma is bleeding between the tough dura mater and the skull. This is almost always an arterial bleed, typically a tear of the middle meningeal artery from a temporal bone fracture.
Because arterial blood is pumping under high systemic pressure, this space fills up incredibly fast.
Yes, it is an extreme neurologic emergency. The volume inside the skull is increasing by the second. Contrast that with a subdural hematoma, which is bleeding below the dura. These are usually venous in origin tears in the tiny bridging veins.
And venous pressure is much lower, so these bleed slower, right?
Right. We actually see chronic subdurals quite a lot in the elderly population. As the brain ages, it naturally atrophies and shrinks away from the skull. This creates tension, pulling those little bridging veins tight. A seemingly minor fall can tear them, and because the bleeding is so slow, it might take weeks for the venous blood to pool enough to show symptoms.
But let's jump back to the epidural hematoma, because the clinical presentation is one of the most famous pattern recognition traps in medicine.
Oh, absolutely.
The patient gets hit in the head, they are unconscious at the scene. Then they wake up and seem totally fine. They might even refuse medical care. This is the brief, lucid interval. And then suddenly, they rapidly lose consciousness again and crash. Why does this happen?
It's terrifying because the lucid interval gives you a false sense of security. What's happening physiologically is the initial concussive impact knocked them out, then they wake up. But that torn middle meningeal artery is aggressively pumping high-pressure arterial blood into the skull. For a brief window of time, the brain's compensatory mechanisms, those bouncers we talked about, manage to displace just enough CSF to keep the pressure somewhat stable.
That's why the patient is awake and talking.
Exactly, but the bouncers are fighting a losing battle against arterial pressure.
They just get overwhelmed.
Completely. The artery overwhelms the compensation in minutes. The compliance snaps, the ICP skyrockets, and the patient goes from talking to uncal herniation almost instantly.
Unbelievable. Okay, what about fractures at the base of the skull? Basilar skull fractures. What physical clues are we looking for?
Because the base of the skull is so complex, a fracture there causes very specific pooling of blood and fluid. You're looking for battle sign, which is bruising right behind the ear on the mastoid bone.
Right.
You're also looking for raccoon eyes, which is bilateral periorbital bruising. And most dangerously, you will likely see rhinorrhea or otorrhea clear fluid leaking from the nose or the ear.
Because the meninges have torn, and that fluid might be CSF leaking out of the brain.
Which brings up a critical bedside test. We know CSF contains glucose, and normal nasal mucus doesn't. So the basic test is checking the fluid for glucose. But what's the bedside trap here if the patient has facial trauma?
The trap is blood. If there is, any blood mixed in with that fluid leaking from the nose, the glucose swab test is completely invalid.
Because systemic blood naturally contains glucose. You'll get a false positive every time. If blood is present, you must use the halo or ring sign.
How does that work physically?
You drop the bloody fluid onto a sterile 4x4 gauze pad. Blood is heavier and denser than CSF. Within a few minutes, the heavy blood cells coagulate in the center, and the lighter, thinner CSF separates and spreads outward through the gauze, forming a distinct yellowish halo or ring around the red center.
And procedurally, these rapidly expanding hematomas, especially the epidurals, usually require rapid surgical decompression. The surgeons drill burr holes or perform a craniotomy to physically evacuate the clot because relieving that pressure is the only definitive treatment. But let's talk about priority nursing actions when this trauma rolls through the doors.
First, always stabilize the cervical spine and assess the airway. You must assume a C-spine injury with any severe head injury, provide oxygen, or prep to intubate. Neg-XT control any external bleeding with sterile pressure dressings.
But here is a massive complication and a priority trap. We often put gastric tubes in trauma patients to decompress the stomach, but you never put a nasogastric or NG tube in a patient with a facial or basilar skull fracture.
Yeah, please don't. If the base of the skull, specifically the cribriform plate, is fractured, the physical bony barrier to the brain is broken. If you try to blindly pass a rigid plastic tube through the nose, it can easily follow the path of least resistance directly upward through the fracture and coil straight into the brain tissue itself.
Oh, that is the stuff of nightmares.
You must use an orogastric tube through the mouth instead.
So synthesizing this trauma picture for our 5 things. Epidural is arterial and fast. Subdural is venous and slow. You're assessing for that lucid interval and basilar fracture signs. The danger is unrecognized expansion leading to herniation. Your priority action is C-spine, airway, and CT prep. And the treatment is surgical evacuation.
Right. So if you see a head trauma patient who gets knocked out, wakes up talking, and then rapidly loses consciousness again, you need to recognize they are bleeding from an artery and need the operating room immediately.
And if you see clear fluid leaking from the nose of a trauma patient, think CSF lead from a basilar fracture. Do the halo test, avoid NG tubes entirely to protect the brain, and prep for antibiotics because that open pathway goes both ways.
Which is the perfect transition, actually. We just mentioned prophylactic antibiotics for an open skull fracture. Why? Because when that physical barrier breaks, it creates an open door for microscopic invaders.
Exactly. Whether it's an open fracture or a systemic bug that manages to cross the blood-brain barrier on its own, an infection in this space triggers an inflammatory explosion. And that creates the exact same deadly pressure cooker we started this whole discussion with. Let's look at bacterial meningitis.
Bacterial meningitis is an acute inflammation of the meningeal tissues surrounding the brain and spinal cord. It carries a very high mortality rate. The trigger is usually a bacteria like Streptococcus pneumonia or Neisseria meningitidis.
So what is the step-by-step pathophysiology? How does a microscopic bacteria lead to physical brain herniation?
Well, the bacteria enter the central nervous system. The body's immune system detects them and triggers a massive inflammatory response. This creates purulent secretions, basically thick inflammatory pus, that rapidly spreads through the CSF pathways. This thick sludge physically clogs up the arachnoid villi, which are the structures responsible for reabsorbing old CSF back into the bloodstream.
So the brain keeps producing CSF, but the drain is clogged.
Exactly. The fluid backs up, causing massive cerebral edema and spiking the ICP. Once again, the uninvited guest has overwhelmed the VIP club.
Let's talk assessment. The classic triad of meningitis is
Fever, severe headache, and neutral rigidity, which is a profoundly stiff neck because the meninges running down the spine are highly inflamed. They will also often have severe photophobia or light sensitivity.
But there is a very specific, terrifying red flag related to meningococcal meningitis. You will see a skin rash or petechiae, tiny broken blood vessels on the trunk or legs. You perform the tumbler test by pressing a clear drinking glass against the rash. If the rash does not blanch or fade under pressure, you are in serious trouble. Why is a non-blanching rash so dangerous?
Because that non-blanching rash is the visible surface marker of the most dangerous complication, Waterhouse-Friderichsen syndrome. This means the infection is so severe it has triggered disseminated intravascular coagulation, or DIC.
Oh man, DIC is brutal.
It is. The body starts forming microclots all over the systemic vasculature, depleting clotting factors, which leads to massive internal bleeding, adrenal hemorrhage, and profound, irreversible circulatory shock.
Okay, we need to diagnose this incredible fast. We know we need to perform a lumbar puncture to pull some CSF and figure out what bug we're dealing with. But there is a crucial sequencing trap here. You must get a CT scan first before you do the lumbar puncture.
Right. This goes right back to the vacuum effect we discussed earlier. You must verify with a CT scan that there isn't already a massive midline shift or obstruction in the brain. Because if the ICP is already critically high and you go poke a hole in the lower spine for the LP, you will vacuum suck the brainstem down and kill the patient. CT scan clears the way for the LP.
Once we safely get the CSF, what do the results look like in bacterial meningitis?
You'll see high opening pressure, which we expect. You'll see high white blood cells, specifically neutrophils, and high protein from the inflammation. But the most revealing finding is LOW glucose. The fluid itself will look turbid or cloudy.
Why is the glucose low?
Because the bacteria are living, replicating organisms. They are literally eating the brain's sugar supply to fuel their own multiplication.
That is wild. Let's hit the priority nursing actions. What is first?
First, respiratory isolation immediately. Droplet precautions. Bacterial meningitis is highly contagious. Do not expose yourself or the other patients in the ICU.
Neck ST. We draw blood cultures and assist with the lumbar puncture to identify the organism.
Then you administer 4B broad-spectrum antibiotics immediately. I cannot stress this enough. The exact second the cultures are drawn, you hang the antibiotics, usually ampicillin, penicillin, or ceftriaxone. Do not wait an hour for the culture results to come back. The brain is swelling by the minute.
And what other medications are we giving? You mentioned corticosteroids earlier.
Yes, dexamethasone. Remember how we said steroids are useless for trauma? Here, they are life-saving. You give dexamethasone just before or simultaneously with the very first antibiotic dose. When the antibiotics hit the bacteria die and burst open, releasing a massive wave of toxins that triggers a secondary inflammatory storm.
Ah, so the steroid prevents that.
Exactly. The dexamethasone suppresses that specific inflammatory spike, protecting the brain from a lethal secondary surge in ICP. We also give codeine for the severe head pain because unlike stronger opioids, it doesn't oversedate the patient, allowing us to keep performing accurate neurological assessments.
So bringing our 5 things together for meningitis. Pathophysiology is pus clogging the CSF drains. Assessment is the fever, headache, stiff neck, and petechiae. The massive complication is DIC and shock. Priority action is isolation, then cultures, then antibiotics. And the core treatment is broad-spectrum IV antibiotics and dexamethasone.
Nailed it.
So if you have a patient, maybe they live in close quarters like a dorm room or military barracks, presenting with a stiff neck, high fever, and a petechial rash, you need to recognize they're a ticking time bomb for septic shock and brain herniation. If you see turbid CSF with high neutrophils and low glucose, think bacterial meningitis. Isolate them immediately and start those ID antibiotics the exact second the cultures are drawn.
That is true intensivist thinking in action. You saw the problem, traced the failing physiology, identified the threat, and knew exactly what intervention was required.
It really is an incredible way to approach medicine. We've taken an intensive journey today. Whether we are dealing with an expanding arterial hematoma from a car crash, a swelling bacterial infection from meningitis, or a shifting fluid dynamic from edema, the intensivist nurse is really just fighting a constant battle against the physical limits of the Monro-Kellie box.
We are always fighting for that space. And, if we connect this to the bigger picture, I want to leave you with a final thought to mull over. We spend so much of our time and energy pushing osmotics and elevating beds, trying to lower the physical pressure inside the skull. But the real art of neurocritical care is balancing that pressure with the flow of oxygenated blood.
Right.
The next time you stand at the bedside and look at a patient's monitor, don't just look at the ICP number in isolation. Look at the MAP, subtract the ICP, find that cerebral perfusion pressure, and ask yourself, is this brain actually breathing?
Is the brain actually breathing? That's the question that saves lives. Thank you for joining us for this clinical deep dive. Take this intensivist mindset to your next bedside shift, and we will see you next time.